So this is our first project. The acrylic model here is going to, like I said, simulate the patient. This will be our simulation model. So when you see the pink acrylic model, this is our simulation model. This patient is actually one of my real patients, as well as the upper model is one of my real patients. On the lower, they had 2 implants put in the mandible. They waited 7 months for the implants to integrate to the bone. In that 7 months, they wore their existing denture without the abutments. As you can see in this picture here, in the acrylic model, the patient now has abutments. So the implants were subgingival and there was a healing cap put on top of the implant. If you can think of the manhole cover on top of the plug, so nothing goes inside it. The implant was put in, the cover was put on, and things were laid to rest. The denture was worn on top of it. Those caps were tissue level, if not sub-tissue level, the caps to the implant. We don't have to worry about them as a dental technician because we're not putting them on and we're not taking them off. Those caps seal the implant while it's integrating. The patient wore the existing denture with a rubber soft liner under the denture, like a tissue conditioner, a co-soft tissue conditioner, which is a kind of really soft, rubbery material on top of the implants, as not to disturb the implants while they're integrating to the bone. If something's trying to set in cement, you don't want to keep banging it, right? Or if you're putting the pins in your crown and bridge model, you don't want someone vibrating the desk and all of a sudden things start to move. So the denture was worn for 7 months on top of the implants. The implant surgery, an hour for 2. After 7 months, the caps were removed. The tissue was cleaned up. If there was sutures or if the caps, nowadays the caps should be at tissue height to create some emergence angle for this attachment. So as you can see in the picture in our patient, you don't see the implant, it's underneath here. It's in the bone. What you see is the implant, abutment, the attachment. This attachment is the locator attachment. Many attachments come in different size, shapes, configurations. This is the most popular, so I chose it for our class. The locator attachment. This patient now has 2 implants and 2 locator abutments. These are abutments. These are going to be supporting the prosthetic. So these abutments are in the patient's mouth. I need to now know, how do I transfer the location of these locator abutments into a working model? So the dentist took a preliminary impression with an alginate and a stock tray. The dentist took an impression of the abutments. Let's backtrack. The caps of the healing caps of the implants were taken off. The abutments were torqued in, which are these attachments. They were screwed into the implant. Everybody okay so far? We have 2 pieces so far here now. The implant and the attachment. The dentist took an alginate impression of the patient at this moment, like you would take an alginate preliminary impression for any denture. Now the dentist says, could you please make me a custom tray so I can pick up the location of these abutments? You can have a working model. I can't make the denture on this model. These things, you can see that the bubble of this one is already showing here. Because it didn't even show up. It's so thin, the wall of the attachment. It's just a preliminary model of roughly the location of these abutments. Now I need to make a custom tray. In comes, simulated to save time. I want you to work longer instead of watching me add wax to the model. I think that's kind of boring. So I made a spacer of wax. This spacer can be a wash, could be a whole sheet of wax, depending on the impression material the dentist is going to use. Is it going to be a polyether? Is it going to be a polyvinyl siloxane? Most dentists will use the silicone polyvinyl siloxane impression material, which I have it right here at the front. I'm going to take an impression of this model, my patient. I'm going to simulate it with your custom tray. When your custom tray is completed, you will come to the side. Ashley, Carey, and myself are simulated dentists. Simulating impressions in your tray will give you an impression. So, what have you noticed here about my block out? That I have these two mountains of wax over the abutment. Your question should say why? Why did you add all that wax? Well, in order to understand, each implant system has different impression copings. These impression copings you will receive, these are not simulated impression copings. These are the real thing. Hence this program, DENT 3027, is a very expensive one. And I'm just the guy for that program. So these are closed tray impression copings. If you look closely, they look somewhat like a champagne glass. Happy New Year's. So I needed to add enough wax to house this attachment in the custom tray. So before I add wax, I need to know what I'm doing. Well, I know this is and there's only one for the locator. There's only one closed tray impression coping, sometimes called the impression analog. But I think if we call it the impression coping, that would be easier. So, or the impression pickups, whatever you want to call them. This is a diagnostic tool that we need to use intraorally. So, I've made my custom tray with this block out. As you can see, my custom tray here. The dentist has the ability to border mold the custom tray if they wish. Heavy body, light body, their choice, they're the clinician. But I'm making a custom tray with block out enough to house. In comes my patient now. These snap on to the locator attachment. So I have the implant, the abutment, and now the impression copings. This simulated is my patient. So I will put these on in the patient's mouth. They snap on. Inside here, there is a black plastic washer. The actual attachment that goes on there has different types of retention or different tensions of retention, which we'll talk about a little bit more when we get to that stage. If I open this, and we'll have a little quiz in a couple of weeks, figures it gets stuck in the top. This is the actual attachment over here. This is what's going to be inside my denture. It also has the black plastic working insert. Inside this is interchangeable. The blue would be the least retention. The pink would be, say, medium retention, which I think is like 2.5 pounds, 3 pounds. And the clear one is the most retention. These snap into this housing, which goes on top of this abutment. But this is for later. Let's move them aside. And we can talk about more in detail the attachment and its workings. And there's more retention levels. They have a purple, which is like 10 pounds. They have a green and red, which is for angulated abutments. But that's a discussion for next week. For this week, we need to understand that we have the implant underneath here, which we don't see. We have the abutment. In this case, our abutment is a locator attachment. The locator attachment has a female and a male engaging. You can see there's a button. If you would think of your spring jacket as a snap, if you want to think of that. And this snaps on top. Our impression coping only engages the circumference of the implant. The actual attachment engages the inside and the outside of this ring. Can you see the ring here? The actual attachment engages the internal and external. The impression coping just engages the external. Because we need it tight, but we don't need it too tight that it won't come off with the impression. Right? Just decent tension. And this black attachment is the working insert, or the black attachment is for the dental technician and the dentist for impressions and the least retentive part. So now this is my patient. What have I done? I've put in 2 locator implant, 2 locator impression copings. Impression copings on top of the abutments with a spacer from my custom tray so I can pick up my impression. So the whole idea is to make a working model as such. Keep in mind the pink model is the patient. I can't make the denture in the patient's mouth. I need to make the denture and the replication of the location of the locators, which is kind of a double word. I need a model with the location of the locators replicating what's in the patient's mouth. Just like any type of dental technology we do. Our crown and bridge models are a replication of what's in the patient's mouth. If the patient has this in their mouth, well, how do I go about replicating that? I took an alginate in my preliminary. That's not going to work out too well. These things will break down in stone. I need actual attachments in the model. Now, the real locator attachment is gold, or no gold alloy in the patient's mouth. I simulated with the stainless steel ones because it's less expensive. I will show you the gold ones and the actual attachments next week and the week after. So simulate that this acrylic model is the patient. These are gold. The impression copings snap on. You will each receive 2. We're actually doing the dentist's work, but we need to understand what they need to do so we can understand what we need. We're going to help our dentist over here. And then I have my custom tray, which has enough room. So make sure your custom tray is not binding on the impression copings. You'd hate for the dentist to go in and knock a coping off. Then your impression is not accurate. So now I will simulate as the dentist. What the dentist is going to do, they'll probably use a light body and a heavy body silicone. They can choose to do whatever they wish, but as a practitioner myself, I would inject around this intraorally. Sometimes it takes an assistant, or I need to be really clever with 2 hands only. So what I'm going to do prior to that is the dentist should use an adhesive. An adhesive is a glue to put inside my custom tray. My custom tray does not have any holes. So this adhesive is going to have the silicone adhere, stick to my custom tray. So the dentist should have an adhesive. If they don't have an adhesive, then you must make some mechanical retention in your tray and make holes. Perforated tray. You with me so far? Some dentists will prefer the perforated tray, but I would make the closed tray. Because I'm usually going to make a functional impression, not a mucostatic impression. So I don't want any holes to take the pressure off me putting tissue, slight tissue pressure on the tissue. Not blanching it out completely, but slight pressure. So I've got the glue in here, and I've got my light body in this gun, and I've got my heavy body in this gun. So what I would normally do, and I'll simulate, this is what we're going to do today as a class. Once you're finished your custom tray, come over to the side, and we're going to take a light body impression of this. So there's no air bubbles. I need a positive replication of this. So I'll probably inject that in the patient's mouth, the light body. Obviously air syringe the saliva out of the way and all that business. Probably retract the lower lip with my left hand or have an assistant or cheek retractors. And then I'm going to load the tray. And if we're a little behind, we can let you do this if you want, but it's more of the dentist's job. I'm going to overload the tray a little bit more than I would because my acrylic model doesn't have a gag reflex or a hyperactive tongue. There's no tongue here, so it's really simple. But then I would insert this in the patient's mouth. My tray had some finger rests at the back. My tray has a handle straight up and down, but not over the vertical dimension of a denture, like over the retromolar pads. So it doesn't interfere with the top ridge or top teeth if the patient has their own natural teeth still. Now, this will take a little bit longer to set because in the intraorally, the patient has a mouth temperature, 95 plus. That is going to speed up the setting time of my silicone. My acrylic model is room temperature. We have no saliva here. At this time, I can border mold. I can border mold. I'll retract the cheek. I'll ask them to lift their tongue and left and right. And this is another reason why I put the finger rests. So if they move their tongue left and right, it just doesn't go straight left and straight right. It will have to come up to go over the teeth, which will simulate the proper width of my internal oblique border molding ridge here. The buccal shelf, I ask them also to move their jaw left and right, and this will thin out these areas here, where we have the end of the zygomatic arch here, which will give me the width of my border of the denture. That's why the denture here is with preliminary impressions. If we make dentures on preliminary impressions, it's always too wide here in this area. There's usually a little notch out, as I've simulated here. The denture has like a little S notch, most of them here. So, while that's setting, let's recap quickly. We have the preliminary, usually an alginate impression of the abutments. What did the dentist do? Wait 7 months, 6 months, 5 months. I've even had as short as 6 weeks. The implants have osseointegrated in the patient's mouth. Take the caps off, the covers of the implants. They're just caps. We don't have them here. You could, but this is an overdenture now. Let's not mix the fixed prosthodontics with the removable. The patient is wearing the denture over the caps. So in hindsight, in some other words, the denture is a temporary. The denture they're wearing over the caps with a soft liner. The caps are tissue level. If the denture needs to be relieved because it's hitting the caps, so be it. The dentures are relieved a bit. Existing dentures in these two areas. A little soft rubber material is put in. Patient goes on 2 months to 7 months till the implants have integrated to the bone. How do they know that? They take x-rays, radiographs. They can see that it's integrated. They might even do a little physical test to see if there's any kind of rotation, which I hope not. They take the caps out. They screw in the abutments. Those abutments can be any type of attachment. We've chosen for this program the locator attachment. It's the most popular. It could be a ball attachment. It could be magnets. I keep saying that, I don't know why. We're not that popular. The locator attachment, the equator attachment, and so many others that aren't coming to my mind right now because they're not as popular. But the principles are the same regardless of the attachment. They all have an abutment. That abutment has a configuration. Male, female, external retention, internal retention. different types of levels of retention with the nylon inserts. Some now have a PEEK, if you're familiar with the PEEK material, that they have PEEK inserts, which are longevity is more than the plastic or nylon. It's like a artificial bone type quality. So the dentist screwed in the abutments. After screwing in the abutments, they're going to do impression copings. That snap-on custom tray is made beforehand. Now this is where it can get a little bit confusing. If we look at some text and some literature, needs to be understood. This is the indirect way of doing this attachment case. Indirect meaning it's not done directly in the mouth. It's done indirectly with the laboratory. The dentist could reline these attachments in the patient's mouth real time. We make a denture, they create 2 big holes and reline it with chairside acrylic right in the patient's mouth and pop it off. I'll show you pictures of that so you'll understand the difference. So I should have prefaced that at the beginning. This is indirect. There's indirect composites, there's direct composites. We can make porcelain inlays, or they can do composite fillings in the patient's mouth, if that helps you understand indirect and direct. We're doing this indirectly, away from the patient. How did that happen? Preliminary impression, alginate of the abutments. Custom tray was made to accommodate the impression copings. We need to know the height of the impression copings. You're gaining experience today, I give them to you. You can look at them and say, okay, they're that high. I need that much wax plus extra material around it. I don't want the tray binding on the impression coping. Better to err wider than narrower. It's only just a little bit more silicone. Once the impression is set, the dentist will not put a spatula in the patient's mouth, but there's saliva. I didn't put any silicone, I didn't put any Vaseline on my model. Silly me. And then the impression is taken out of the patient's mouth. As such, perfect impression. No bubbles, no voids, no gaps, no nothing. I used light body, which is a higher detailed replica, and then I injected that in the patient's mouth. You can go as far back as last week, but the dentist didn't do that, and now the impression coping is wobbling in the impression. This is not good. If the impression coping is not secure in the impression, then my angulation and position is off. What do I do now, is your question, and should be your question. Okay, the impression, this came in the box. We will simulate it. I love simulation. To a certain extent. Nothing like the real performance. This is good. So, in comes the laboratory box to the lab, and out comes the impression. What do I do now with this impression should be your question. Great. You're on your co-op. Pour the impression. What do I do? I need something, which I'm going to show you, which we're going to get. If you pour stone into this, that's the wrong answer. You need to have a replication or replicas of the abutments. In comes the abutment replicas. So these are replications of the locator attachment. They're stainless steel, they're not gold, and they have retention grids at the back that will hold it in the stone. What do I do with these? I snap them into my impression copings. They snap in. You with me so far? Now I make my model. I pour the base. Ideally, if you don't have any good control with the stone, you can beat it and box it. Best practices. Or you can try to do it all in one shot, which is probably what I would do. But you need to be good at it. Because what happens is, I want to see your final impressions that look exactly like the patient. I don't want to have stone where there's a tongue. I don't want to have stone way up high. I want a 2 millimeter border that would happen if you were to bead the impression. right? Now, it's kind of easy because you have the border of the old one. Yes. Oh, the soft tissue model. Hang on a second now. This is an excellent question. My attachment here is supragingival, above the gingiva. There's nothing subgingival. There's no soft tissue model. If I chose to make a soft tissue model at this point, how am I going to process my full denture in the flask? It's going to stick together. Then I need to make a duplicate of my soft tissue model to process the denture in acrylic. So in this will be all stone model because everything, as you can see, is above the tissue. In subsequent weeks, we'll talk about parameters for the locator attachment and most attachments that they should be tissue level, not any higher. One thing I failed to mention today, that this attachment or this abutment comes in 1, 2, 3, 4, 5, 6 millimeters in height. Because if the implant is driven subgingivally, I need to bring the attachment above the gingiva, then I need to choose how high of an abutment I need to come just above the gingiva. When I look at my preliminary impression, I have no idea if that's a 1 millimeter abutment or a 6. Because I'm just looking at the top of it, which is just above the tissue. So good question, but we'll park it for the fixed prosthodontics at subgingival implant level impressions. This is an abutment level impression. So maybe to talk about that a little bit more in depth, if I have another patient here with a ball attachment, as you can see here, if I unscrew the abutment, now we have the platform of the implant. Can you see that? This is an actual implant, or Nova implant, or Nova Lab, whoever made the model. I have my implant. This is the patient, by the way. Or I have my abutment. In this case, it's a ball attachment, which we're going to talk in subsequent weeks, next week and the week after, about balls and locators and all kinds of stuff. So do I take an impression of this? Then I need my impression coping for the ball. That comes different than the locator, obviously. If I'm going to take an impression of the implant, at the implant level, then I need impression coping that goes in that. And then decide if it's a closed tray or open tray. Confused it looks, possibly, but I think it's all going to come clear in the near future. Who decides this? The dentist. They're going to tell you in their prescription, please make a custom tray closed for an implant level impression. Okay, so I don't need any spacer on the top here. Maybe I need it open. Or do I need a spacer? How high is this impression coping closed tray? For the locator, you know it. I'm giving it to you. But if you're doing another system, you need to know how high they are. If it's closed tray. If it's open tray, I'll show you in the next projects the open tray. But most often, I'm trying to stay mainstream here. Most often, for cost, speed, accuracy, the dentist will torque down the abutment. The most popular these days seems to be the locator. They had a patent, the locator. Patent lasts 50 years or so. Just expired. So now everyone's making locator looking attachments. We have equator. We have Lodi attachments. We have locator 2. They patented a new design. So your goal today, number one, cognitively understand the process. Because if you're out of the process, I don't know what's next. I need to know the appetizer before the first course, before the second course, before the dessert. I can't be thinking of, put one thing in front of the other. Alex.
Are you allowed to use different implants for the same patient?
That's an excellent question. And I've got pictures here to show you of a client that I did just prior to the holidays, where they had one locator on one side and 3 equators on the other side. They also had 2 implants buried that weren't even going to be used. So I have no history of this client except what I saw as a result of maybe one implant failed and another guy put in a different type. But it worked.
Another question. How can we identify it? If you look almost the same with each other, it seems that it's very difficult.
This is a good question too. The locator is very obvious. It's most popular. You'll notice it. You could recognize it. You'll recognize it after this class. Sometimes I even go on to, okay, I'm a past millennial, Facebook. No one uses Facebook. But there are prosthodontic groups, and people will post, does any idea what this is? And it could be a Sika attachment from 1984. It could be something that's not being used, and someone say, where do I buy it? Like they're discontinued. Or some company will buy another company and call it a different name or discontinue it. So all these things need to be understood. The best is to call the dentist. It's in the chart. That dentist died. The charts, who knows where they are. The patient forgets their dentist's name because they have Alzheimer's. They said, who's your dentist? My mom. Your mom passed 80 years ago. But she pulled my tooth. Like all kinds of things can happen. Right? So information is gone. It's lost. Now we have what to look at the patient's mouth. The records, chat groups, I've even shown a picture with, it's so easy these days with your phone, you can send a picture to the sales rep of a implant company that sells many and say, what does that look like to you? And they'll say, oh, it's this. And I had to do that as well. So it's not like you're left in the dark. You've got so many resources to find out what it is. I don't think I've seen anything that nobody knew what it is. I can also share, if you saw the video when Toronto started doing their own implants, their Overdenture implants were these custom-made attachments. They look like a mushroom, if you could visualize a mushroom. And this was screwed into the implant, and this was the healing abutment and the abutment. And I saw those patients in my earlier days, and I had no idea what that was, and then found out it was one of Dr. Zarb's free study patients. You know, being Toronto, GTA, you're going to see these people. And then had to make a denture that fit over that. There was no attachment. It was a soft liner that engaged the undercuts of these mushrooms. There was no male-female. So, what am I going to grade you on is the replication of your model. If we can't give you a good impression like that, then obviously you can't make a good model. But if we give you an impression like this, and this happened in the years subsequent to this one, obviously, that I don't see the custom tray anymore. It's covered in stone. Where's your tray? It just got swallowed up by calcium sulfate. Swallowed up. The impression is intrinsically embedded into a ball of stone. You're going to have a hard time making this. I'll come in the plaster room and try to help you. I think by the end of today, if we can at least secure this, would be a goal. What are we going to do next week? We're going to have our model, and then I'm going to talk about making the framework. While we're making the framework and duplicates and waiting for impressions, you have an upper model. This is my final impression, probably 6 or 8 weeks post extractions. You can still see the clefts of the model, the sockets. I'm not going to ask you to make a custom tray. You can go ahead and make one if you feel that you need exercise. But I'm going to ask you to make an occlusion rim on the upper. So if you're waiting, make the occlusion rim on the upper. Do we need to discuss the occlusion rim? If I show you this occlusion rim from the intraoral surface or the intaglial surface, you can see that I did not put any light cure into the sulcus. This has a lot of undercuts. Would you not agree? You can see my light cure. If you can't, I'll outline it. It comes maybe from the first bicuspid, around the incisors papilla, and that's the extent of my light cure. If I did it on the model, and then cover the tuberosities, and maybe a little bit. No. No, this is a good question. Many people make the post-dam in the occlusion rim, but I would usually use the occlusion rim as a test of how far dorsally or posteriorly I could go on the patient. Because the further I can engage onto the soft palate, I can create more suction. But if the patient can't tolerate it, then I have to shorten it. If I've committed to a post-dam, then I can't change it. So that's why I usually do a wax post-dam beyond my custom base plate. So when I'm doing my bite registration, I will cut the wax to where my denture is going to finish. And then I'll put the post-dam in for processing at that spot. Just made sense to me. Because once I commit to it, then I could be wrong. Even though technically we know, okay, it's anterior to the palatine fovea, junction of the hard and soft palate. Everyone has this ambiguous location of the post-dam. But I would like to go as far as I can, whatever the patient can tolerate. Even if I'm engaging the soft palate, the suction is created tenfold. But if they can't tolerate it, I'll come more anterior. So we have an occlusion rim to make. Your occlusion rim must look awesome. You're a third-year student now.
Yes.
If I see any funny business with the occlusion rim, back it goes. And then I can say, make the custom tray now. So